Antibiotics in community-acquired pneumonia. Empirical antibiotic treatment is required at diagnosis of community-acquired pneumonia in the absence of microbiological information. Empirical antibiotic choice may be based on the site of care, either community versus or hospital, or on community-acquired pneumonia severity. And in some countries, severity-based antibiotic guidance is recommended based on the Kerbis score. The typical empirical antibiotic choices for community-acquired pneumonia will be discussed in the next video, but prescribing of empirical antibiotics should be in line with local protocols and should consult hospital prescribing guidelines and liaise with microbiology if needed. Strongly consider narrowing antibiotics coverage if a specific pathogen is identified. General points include early antibiotic administration is associated with an improved outcome in community-acquired pneumonia. Immediate antibiotic administration in the community is recommended for patients with suspected life-threatening community-acquired pneumonia. Confirmation of community-acquired pneumonia with a chest X-ray and antibiotic administration should occur within 4 hours of hospital admission. In general, use single antibiotics as initial empirical therapy in low severity and dual combination including a macrolide for moderate and severe or high severity community-acquired pneumonia. IV antibiotics should be administered immediately to patients with high severity community-acquired pneumonia. IV antibiotic will also be required in patients with non-severe community-acquired pneumonia who are unable to safely take oral macrolides or oral medications such as unsafe swallow or impaired conscious level. Oral antibiotics should be used in those with managed community-acquired pneumonia and those with low or moderate severity hospital-managed pneumonia with no other contraindications. Consider adding anaerobic antibiotics cover metronidazole, for example, if aspiration pneumonia or lung abscess is suspected. Document indication and plan duration of antibiotic treatments and stop antibiotics if it becomes apparent that they are not indicated. We should review the need for IV antibiotics daily and aim to switch from IV to oral antibiotics as soon as possible, usually when a patient has shown clear response to treatment and has been apyrexial for 24 hours. A switch to oral co-amoxiclav and not an oral cephalosporin is recommended after treatment with IV cephalosporins. For those treated with benzyl penicillin plus levofloxacin, switch to oral levofloxacin plus or minus oral amoxicillin is recommended.